Welcome, everyone, and hello. My name is Elisa Klein, and I'm the Director of NERI Press and Training Center. I'd like to welcome you to today's webinar, Assessment of Problematic Sexual Behavior in Children, What, When, and How, presented by Dr. Erin Taylor. Thank you all for being here. I'm in the middle of a snowstorm in Western Massachusetts, and you might hear snow plows in the background. I hope you're all comfy and safe. Before turning this over to Erin, I'd like to take a few moments to tell you about NERI Press and Training Center. Our mission is to share cutting edge research and best practices emerging in our field. For many years, we've accomplished that mission only through book sales, but with changes in the last several years in the publishing and technology worlds, we've continued our mission by expanding the ways in which we disseminate knowledge, like this webinar series that is delivered by our internationally recognized authors and other experts in our field. Additionally, over the last 6 years, NERI Press has offered online courses, a free monthly research to practice and policy newsletter, and in-person trainings. It's important to us here at NERI Press and Training Center to hear from you what kinds of information, training, resources, and books you want and need to be the best professional you possibly can be. So please contact us with your suggestions, your input, questions, and feedback, whether positive or negative. We would love to hear from you. We have a little poll for you. We'd like to know how many of you have participated in a NERI Press webinar before. Okay, it looks like more than half of you have participated before, about 65%. That's great. We're glad that we have repeat customers because it tells us that we are doing things that are of interest to you. So thanks for filling out that poll. I'll talk about this more at the end of the webinar, but I'd like to make a pitch that if you find these webinars helpful, we would love it if you consider becoming a sponsor of our webinar series. NERI Press and Training Center is actually a nonprofit organization, and as such, it's your sponsorship that helps make this series happen, and most importantly, that allows us to offer the webinars for free to the thousands of clinicians and other professionals who have participated in them over the last several years. So please consider becoming a sponsor of the webinar series. If you do become a sponsor now, you're guaranteed seats to not only this season's remaining webinars in April, May, and June, but also to all webinars in the 2018-2019 season, so next year's season. We will register you and 15 staff members of your organization for each webinar, offer you a free gift of 2 of NERI Press's books, and we'll mention you, of course, in all of our publicity about the webinar series and in each webinar. Before we get started with Erin's presentations, there are a few more things I'd like to share. As with all workshops, I want to convey the learning objectives to you. Let's pull that slide up. There we go. Participants will learn about recommended structures for an assessment of children when there are concerns about sexual behavior, learn suggested interview topics and approaches with children and their caregivers when assessing concerning sexual behaviors, and lastly, learn about standardized measures that can be used in the assessment of children when there are concerns about sexual behavior. I also want to let you know that the YouTube recording from this webinar will be posted on the NERI Press website within a week after the webinar's completion. Slides are currently ready to download, so the slides that Erin will be sharing with you shortly will be ready to download from the NERI Press webinar page at neripress.org/webinars if you'd like to follow along. And as I think Tim mentioned at the beginning of the webinar, you can also download the slides from right here on your control panel on the right-hand side. And last, when the workshop is over, please be sure to answer the short survey at the end. We love your feedback. And in about a week, you'll receive a follow-up mail with a link to the recordings and to a certificate of attendance that you can download. I'd like to introduce our speaker finally, now that we got all of that business out of the way. This is Dr. Erin K. Taylor. She's an assistant professor at the University of Oklahoma Health Sciences Center. She's a licensed clinical psychologist who provides treatment for children with problematic sexual behavior. As a member of the training and technical assistance team for the National Center on the Sexual Behavior of Youth, also known as NCSBY, she provides training to clinical teams across the nation. Dr. Taylor is actively involved in research examining youth with problematic sexual behavior. And as I think most of you know, this, this webinar today in our mini series set within NERI's webinar series, and there will be another one with faculty also from NCSBY next month. But we are very pleased this month to have Erin K. Taylor. So Erin, please take it away.
Hello, everyone. I'm going to pull up my screen now. Give me a second. Is my screen showing? I'm sorry. There we go. Give me 1 second to get this started. Apologies. Okay. Hopefully that's the correct one and not the note version. So thank you all for having me here today. So as we were just talking about, the goal or the topic for today's webinar is the assessment of problematic sexual behavior in children. What to assess, when to assess, and how to assess those behaviors. So the goals for today's session involve, discussing the structure of the assessment, what techniques or questions you might utilize when assessing sexual behaviors in children, what are other important related factors to assess, and then specifically kind of what useful assessment measures we might use and we would recommend. I've included a lot of information on today's slides, and just because of our time limits and the amount of information I'd like to get through, we'll only be able to touch on a lot of these topics and won't be able to go in quite as much depth, but I did try to put additional information on the slides so that you would have that for reference. Sorry, there we go. So just to kind of get everyone off on the same foot, or same place, I also apologize. This slide is a little bit later in the handouts. I moved it earlier just today because I realized I wanted to have the definition sooner in the presentation. But when I'm talking about problematic sexual behavior, or PSB, as I'll probably interchangeably refer to them throughout the webinar, I'm talking about behaviors that involve sexual body parts, so genitals, anus, buttocks, or breast, in a manner that is developmentally inappropriate or potentially harmful to the youth or others. As was mentioned earlier, this is a webinar in a series of other webinars. So if you're interested in more information on just sort of general information about problematic sexual behavior, kind of an overview of definitions and origins and risk factors and protective factors, I'd encourage you to go back and view last month's webinar with our team's director, Jane Solofsky, if you'd like more of that information. So the goal of clinical assessment of children with problematic sexual behavior, there are multiple goals, I guess, when you're conducting these assessments. So the first and most obvious would be, is there a problematic sexual behavior? So understanding, does the child have a sexual behavior, and does it rise to the level that we would consider it to be problematic? There's also important information that or what you would use from your assessment to design the treatment plan and form your clinical decisions around what treatment you would recommend. We're not going to talk about that today. Again, that will be in next month's webinar if you're interested in that topic. In addition, the assessment of PSB can really help to inform safety planning for the family at the home, school, and community level. Again, we're not going to be able to talk about that in detail today, although we will talk about it briefly as it relates to assessment. So just kind of as noted, this first bullet point, is there a problematic sexual behavior, is largely what we're going to be focusing on today. Excuse me. So the one of the first questions we kind of want to think through is, when do we assess youth with problematic sexual behavior? So kind of help us think through the structure of the assessments that we conduct. The most obvious, and the one that many of you are probably already doing, are an initial focused assessment or an intake assessment of problematic sexual behavior. During that assessment, you're going to be looking at multiple areas of functioning and behaviors, as we'll talk about here in a moment. One important note about the initial focused assessment or this intake assessment is that we really want to be careful to not conduct this assessment until after any investigation by law enforcement or Child Protective Services or other systems have been completed, or that they're closed. We want to be careful that we are not seen as potentially influencing or even appearing to influence what a child says about their sexual behavior. So we just want to make sure that that investigation is closed. We also want to be careful that when a child is of an age that they could be charged, that there's an agreement or an understanding with the court system that what they share in treatment will not be used against them in court, or will not be requested for use in the court system. And so we want to make sure we're coordinating with the court system and regarding the investigation and all of that for those children who are involved in those systems. Outside of that initial assessment, we also that we'll be focusing on mostly today, we also want to think through or have assessments later throughout treatment. So we like to do ongoing assessment throughout the course of treatment. So when we say ongoing, basically every week when we have a treatment session, we are doing a very brief assessment about whether the child has broken any of the sexual behavior rules. We'll talk about what our rules are here in a little bit, but that way it gives us a quick assessment of how they're doing, if they have engaged in any problematic sexual behavior in the previous week, so that we can monitor their progress. If there are other areas of concern, for instance, maybe the child has trauma history and has some trauma responses, we may also want to be doing some semi-regular trauma assessment to ensure that treatment is helping with those symptoms, or at the very least not causing a spike or an increase in trauma symptoms. We also like to do assessment towards the end of treatment. That particular kind of graduation or closing assessment helps us to make a determination about whether a child is ready for graduation or ready to complete treatment, and also helps us to make some determinations about whether any other services are indicated. So it may be that their problematic sexual behavior has significantly declined and is being managed well, but perhaps they are still having a trauma response, or they're having some mood symptoms that we would then want to refer them on to another provider for. For those of you who are on last month's webinar, this chart probably looks very familiar. This is a chart that we use to help us make determinations about if a sexual behavior should be considered problematic. And so it can be really useful for our assessment purposes to be thinking through, are we assessing the frequency, making sure we're assessing the developmental considerations, and also assessing harm. So when I talk about frequency, what that means is the behavior that the child is showing, is it occurring at a really high frequency and to the exclusion of other activities that the child may be involved in? And has it been unresponsive to typical parenting strategies or parental intervention? We also want to, again, look at that developmental considerations piece. So are the sexual behaviors, or did it occur between two children of significantly differing ages and or developmental periods? So we don't want to just say ages, because what we know is that, occasionally we have children who are functioning at a lower developmental level than their age would suggest. And so if a behavior, were to occur between two children of the same age, but one of them was much younger in terms of their developmental functioning, then we would be more concerned about that behavior. There isn't really a cutoff in terms of the number of years for age or development, but the larger that gap, the more concerning it is. We also want to look at if behaviors are occurring longer in duration than developmentally expected. So it's not uncommon for 2- and 3-year-olds to be naked and be nude because they don't really have a sense of themselves from others. It is not common for 12-year-olds to be doing that behavior. And so we want to look at, are these behaviors that maybe had been typical and the child hasn't really aged out of them as we would expect. We also want to make sure that we're assessing for harm. It's a very important factor. So are the behaviors that the child has engaged in intrusive? Is there penetration involved or direct contact between genitals or oral genital contact? Does the behavior include force, intimidation, or coercion? So are they causing fear or anxiety in other children? Those behaviors are concerning if they happen one time. And so we want to make sure that we're assessing for harm as well. This is sort of my confidence building slide for those of you who maybe haven't done assessments of problematic sexual behavior or are feeling a little bit nervous about doing that work. I want to assure you that the assessments for problematic sexual behavior don't look inherently different than other clinical assessments. So if you are working with children in a clinical setting and doing assessments of other behavioral health areas, the structure and the process is going to look very similar. In fact, we'll be talking about things later and you'll probably be like, that's it? Like, isn't there more? So it is very similar to the work that you're already doing. Obviously, the focus is a little bit different, and it's going to be focusing on those sexual behaviors, which can feel more challenging to discuss, can be a little bit more intimidating for those who have less familiarity with this topic or didn't receive training on this, and the vast majority of us do not receive training on how to assess for sexual behaviors in children. But this is my slide of saying that you can do this. If you are working with children and you are assessing them for other behavior concerns, you can assess for problematic sexual behavior. So it's kind of my you can do it slide. So thinking about the assessment structure and what the structure excuse me, could look like, I want to kind of comment or recognize that there are a lot of different structures for how you can organize your assessments in order to obtain all of the necessary information. In our own work, this is the structure that we use, but again, there are multiple options, so you don't have to follow this exactly. But within our work, what we do is we are fortunate to have a lot of trainees and staff involved in our program, and so we are able to conduct caregiver and youth interviews simultaneously. But what we do within our clinic is we first bring in the caregiver and the youth together initially. And during that initial, 10 or so minutes, we review our typical intake materials like you would, whatever paperwork you would need for your clinic, as well as talking about confidentiality and the limits to confidentiality. We also want to orient the family to the assessment process and let them know the plan for the day's appointments. Often families are nervous. They may have been through a lot of other appointments before they've come to our clinic. So we want to be really clear about what we are going to be talking about during that appointment. So we're very clear that this is a clinic that assesses sexual behaviors in children or concerns in children or children who have broken sexual behavior rules. We also like to have a conversation with the family and particularly with the child to promote honesty and to talk with them about what to do if they have bothersome emotions. So when I say promoting honesty, this isn't us sort of saying we really need you to tell the truth or giving them a sort of a hardline approach about being honest, but more that we want to talk with them about the importance of honesty, what being honest means for them, and then talking about the fact that if they are feeling maybe really uncomfortable or feeling ashamed or guilty or other heavy feelings, that rather than not telling the truth or not being honest or telling that they don't know, kind of telling us that they are having those heavy emotions so that we can help them calm down and feel better as we're talking about things and so that we don't make it worse. Throughout this conversation in the beginning, part of why we have this is to make it clear to the child that the caregiver knows what they're going to be talking about and that we've gotten permission from the caregiver to have conversations about these private topics, and that everyone kind of knows what we're there to talk about. And we're modeling those appropriate boundaries about privacy and getting permission and things like that. Once we have that initial time together with the family and the providers, we then split and conduct separate caregiver and youth interviews. Again, that's not always an option for other clinics where the staff, where there aren't, a lot of trainees, or for billing purposes. And so other clinics, what they've done is sort of had a place where the child can wait, can engage in play while the caregiver component happens, and then they follow up with the child once the caregiver piece is finished. Other clinics have separated it where they do them in 2 different weeks in order to get all of the information needed. Excuse me. And then once our interviews are all done and all of our measures are collected, we do a follow-up, brief, follow-up time with the caregiver and closing with the family to talk through kind of next steps, which we'll get to in more detail here in a second. So for the focused assessment of youth with PSP, what we'll be talking about in more detail is getting information about this history of problematic sexual behavior, kind of ways to assess for that sexual behavior with caregivers and youth. But we also want to assess other areas that we think are going to have could potentially, I guess, have an impact on problematic sexual behavior. So again, for those who are on last month's webinar and those who are familiar with this, this population, we know that trauma experiences can impact problematic sexual behavior, not just sexual abuse, but also exposure to violence and domestic violence or physical abuse. It's not uncommon for children who present to our clinic to have a maltreatment history. So we want to make sure that we are also assessing trauma history and any trauma symptoms that the child may be experiencing, because that's going to really help influence or determine our clinical decision making about what we need to address first. In addition, we also know that there are other, individual vulnerabilities like impulsivity, current kind of just general cognitive functioning, as well as family factors that might be influencing problematic sexual behavior. So is a parent working really, multiple jobs and having older siblings provide a lot of childcare? And is that, causing some challenges with supervision? And so we want to collect just that basic background information you get from a lot of assessments of child behavioral health on social, family, developmental, and school history. So we can get a sense of how the youth is functioning and what is going well for them and maybe where our other struggles are. We also want to collect that same information in terms of emotional and behavioral functioning. Within these factors, outside of there's risk factors, but there's also important protective factors. So we want to also be assessing for, is the child able to, form and maintain healthy relationships? Are they doing well in school? Do they have parents who are really able to provide good guidance and supervision? So we're wanting to kind of across all of these areas, look at things that might be of concern and might promote sexual behavior, or at least be sort of maintaining the sexual behaviors, as well as what are protective factors or things that we would capitalize on and really want to bolster in the course of treatment. We also can follow up with more intense assessment as needed. So for instance, if a child comes in and they maybe have some developmental delays or lower cognitive functioning that's of concern, or autism spectrum types of symptoms, we may want to do more follow-up in a second assessment or with a different, with other structured assessment measures to collect information on that as well. That may not be standard in your general PSP assessment. So now I want to talk a little bit about that caregiver interview. And again, this is what we sort of just talked about. All of these different pieces of information that you're going to collect in the caregiver interview are going to be helpful for that clinical decision-making purpose. And what we're going to focus on primarily is that detailed history of the youth's sexual behavior. But again, just like we spoke about all of those other areas, trauma history, social history, school, etc., you're going to be asking the caregiver about in the course of your interview with them. We also like to make sure that we review with the caregivers what the sexual behavior rules are. And again, I'm going to talk about that a little bit later when we're discussing how we use it in the child interview, but we want the caregivers to know what it is you're going to be talking with the child about. So we make sure that we go over those with the caregivers so they are clear on and are comfortable with what you'll be talking to the youth about. When we're thinking about collecting information for problematic sexual behavior, it's helpful to think about how you would assess typical behavior problems. And in typical behavior concerns, general defiance or oppositionality, we find it useful, or can be very useful, to have this ABC model: the antecedent, what's happening before, the behavior, what actually happened, and then the consequence, how did others respond, or what was the consequence of the behavior. And similarly, again, like you would use for more of a general or typical disruptive behavior, you can use this model for problematic sexual behavior as well. Some of the specific questions you're going to want to be addressing, the most obvious of which is what happened. Just getting a story from the caregiver about what occurred and what they either believe occurred or saw occurred or know to have occurred. We want to make sure that we are assessing where the behavior happened. So is this something that's only happening at home? Is it happening at school, on the playground, on the bus? Want to get a clear picture of kind of the different settings that these sexual behaviors may be occurring in, because that's going to help, again, inform those safety plans that you'll be helping to develop. Thinking about that developmental considerations and that definition of PSB, we want to know who was involved. So who were the other children that were involved? How old were they, or how what developmental level were they functioning at? How have they responded? When did the event happen? It's not uncommon for children with PSB to have gone through potentially multiple systems, or they have involvement in juvenile justice or law enforcement, particularly for older youth. And sometimes they will come in for an assessment, and you'll find out that the PSB happened 2 years ago or more. And so we want to make sure we're asking and not sort of just making an assumption that the behavior happened recently, and that's why they're now coming into the clinic. Sometimes they've been held up by other systems and couldn't get into treatment until several years after the behavior occurred. Again, thinking about that definition of PSB, we also want to look at that duration. So did it happen one time? Did it happen multiple times over the course of a year? And that frequency. So how often is it happening in a day or in a week or a month? So that we can get a sense of, again, is it a high frequency behavior? And want to be, again, of course, looking at that force, coercion, and aggression if that was used. In addition to those pieces of information, we also want to be assessing whose the idea of the behavior was and where did the idea come from. So some children, as we know, are followers, and so they may have been egged on or had it suggested by other children, and they acted out these behaviors because of that. That's going to, again, be important for you to know when thinking through treatment planning in terms of peer relationships, as well as safety planning. And sometimes children have gotten the idea from they've witnessed inappropriate things or sexual behavior between adults, etc. And so we just want to have an idea of where it came from so that we can take that into consideration when treatment planning. Also want to know how did the other child respond or react. If it was a child that the family knows, perhaps a sibling or another family member, a peer, we want to, potentially, if needed, be able to provide them with a referral to evidence-based assessment or treatment should they be having a strong response to what occurred. But also, in terms of helping to understand how the child may be conceptualizing this behavior, having a sense of how the other child responded. So sometimes we'll have situations where children don't have any response to the behavior, and so it can be harder for the child who engaged in that PSB to really understand why it was a problem. So having that information is helpful. How did adults learn about the sexual behavior to get a sense of how covert it was? And then what did the caregivers do to respond is helpful to know. It's not uncommon for caregivers to sort of say, I had no idea what to do, and so they just ignored it. Or they've gone completely the other extreme and they have had really strong responses, and so we want to have a sense of how they've responded. In addition to the information about the sexual behaviors, other important things to be assessing throughout the interview is how the caregiver is responding kind of kind of themselves, and how they're thinking about the behavior. Youth problematic sexual behavior can be really isolating for families and very stigmatizing. And so sometimes caregivers have pretty much cut off contact and cut off social supports with their family, with their friends, because they don't know what to say and they don't want people to know what happened. And so throughout the interview, we want to be, validating caregivers' responses and their emotional response to what happened, and trying to provide them with education about potential misconceptions that they have, and providing them with hope. So this is a serious situation, but we can help your family. And I think more so than other assessments you have more of that kind of education and hope loop, I guess, that you're talking with caregivers about what we know about youth with PSP, and what treatment can do for the family. So we want to be assessing their response again, so that through the course of treatment, we may want to help caregivers figure out how to reach out to family members or to explain things to their family so that they can have social support. We want to know if the behavior was reported to authorities. You'll have some of that collected at referral, so you're not scheduling an intake before the investigation is complete, but you get more additional information about who investigated and the results, if there are any systems requirements. Who else knows or should know? Again, thinking about that social support for caregivers, and also who else might be in charge of supervising and monitoring this child and may need to know some additional details. And has there been any change in residency for youth? So sometimes children are placed in other homes with family members or in foster care systems. And so we want to know what the permanency plan is. Is there a plan in place for reuniting this family? And are they having visitation between children? Lastly, just really quickly, we want to be assessing what caregivers are doing in terms of their supervision. So when a child has had a problematic sexual behavior, we want to have eyes-on supervision, so they can see the child at all times. And so we want to make sure that caregivers are understanding what that means, know how to enact that in their home, and then help them think through potential other risky times or situations that may make it hard for them to supervise. Like, what are they going to do when they need to use the restroom? What are they going to do when everyone's asleep at night? Moving forward to think about the youth interview. Again, remember, you may be doing this interview later, you may be doing it, someone else may be leading it, depending on how your clinic is structured. But again, when the child is alone with the interviewer or the evaluator, we want to review that purpose again and the structure of the appointment. This is a very nerve-wracking appointment for families and for kids in particular. Once they know they're going to be talking about sexual behaviors, it can be, anxiety-provoking. So we want to engage them in some neutral conversation, just to kind of get to know them, that rapport building piece, before we jump into any information about sexual behaviors. Like we talked about before, we have a conversation again about what kinds of responses they may have. So saving the I don't knows for when they really don't know the answer. Otherwise, letting us know that they don't want to answer or don't want to talk about it, maybe because they're having those heavy feelings, or that they don't understand, and so that we can explain to them better. So we'll walk through those different responses. And again, reviewing that we have a lot of children who come through our clinic who have broken sexual behavior rules, and it's okay for us to talk about here. For the first part of our interview with the children, we want to define private parts and identify the youth's labels for private parts. So the first step of that is showing them an age-appropriate drawing of boys and girls wearing different kinds of bathing suits. This is not the image that we use, this is just one I found on the internet, but something like a drawing where you have them then circle the area that are the private parts on both children, both the boy and the girl, and have a conversation about the fact that private parts are the parts of the body that are covered by bathing suits. Then we let them know that we're going to show them a picture of a boy or a girl without clothes so that we can learn what words they use for private parts. And typically we start with the drawing that corresponds with the child's gender. So these are the actual drawings that we use. And it's just really important for us to understand what names the children use for their private parts, or for private parts in general. They use a lot of different words, and some of them may make no sense to you. They may be completely sort of idiosyncratic to that family. And so having that language will help you decipher what they're reporting about when you're asking about sexual behaviors. Because again, we're talking about sexual behaviors, and now they're looking at pictures of these pictures, it might make them more anxious. And so we'll have them typically start with identifying parts of the body that are like non-sexual, so the head or the foot or the hand, like you can see with the green arrows. And then we follow up and have them identify the parts of the body that are pointed out by the yellow. So what is your term, or what word do you use to describe this part of the girl's body, this part of the body? So we review those parts, and then we use their language throughout the course of the interview so that we aren't making anything confusing for them and that they can follow along. Once we've identified what labels they use for private parts, we like to review and teach those sexual behavior rules. And these are the rules that we teach. It is not okay to touch other people's private parts. It is not okay to look at other people's private parts. It's not okay to show your private parts to other people. It is okay to touch your own private parts as long as you're in private and it doesn't take too much time. It is not okay to use sexual language, and it's not okay to make other people uncomfortable with your sexual behavior. Depending on the level of the child, they may be able to read these out loud, so you may have them read it and then you kind of follow up repeating what they said and maybe providing examples of behaviors that would break those rules. We'd like to include some examples that might be similar to behaviors that they exhibited so that they can see that that behavior breaks a rule and it's okay to talk about. Once we go through the rules, we kind of follow up with a pretty simple question, just asking, what rules have you broken? Or have you broken any of these rules? Kind of depending on the child and where they're at and their openness. Some children will then point to the number of the rule on the page. Others will say what they broke. We would like to make sure that we're attending to the child's emotions during this. And so if it seems like they're getting really nervous or anxious or withdrawing, recommend doing a relaxation exercise, so teaching it to them and providing encouragement for them to use that to help decrease their discomfort. And then if they do share, praising them for, I know how hard it was to admit that you broke the rule of touching someone else's private part, and I'm so glad that you were honest with me. For each rule that they talk about breaking, we want to collect details about each incident, which I'll talk about in just a second. But once we've gotten the details of one incident, we want to make sure that we ask, was there any other time that you broke that rule? Or tell me about the other times that you broke that rule if you kind of have a knowledge of their history. And then once you've gone through one rule, making sure to not to assess the other rules again. So what about the other rules? Tell me about times that you've broken the other rules. Sometimes children will kind of feel comfortable talking about one topic, but then there are other rules that they would have less comfort, and so they may try to avoid. So we want to make sure we're at least assessing for those other, for all of the rules. Similar to what we ask caregivers about what occurred with the sexual behavior, the problematic sexual behavior, we're going to be asking similar questions of the child at a developmentally appropriate level. So if they were looking or showing or touching their private parts, what private parts did they see or show? If there was touching involved, what did they use to touch? So was it their hand, an object, their mouth, their genitals? Again, excuse me, whose idea was it? And then also wanting to assess what was the intention of the behavior. We're not going to ask them what the intention of their behavior is, but we want to have an understanding of what did they intend by it. So for instance, if children are engaging in a lot of self-touch behaviors, is that something where it appears that it is a sort of a self-soothing or calming behavior, and that's why they're engaging in it at a high level? Or is it more because they enjoy the feeling and it's developed into a habit for them? If they're using, sexual language, was it something where they were joking around with friends? Or was it something that they were, using that language to be malicious or have malice against other children? So assessing that intention. We want to look at how covert the behavior was, what the status of clothing was. So did rules break, were rules broken in terms of touching over clothes or under clothes? Was there penetration involved? And was there use of electronics? So it's not super common that they would have maybe taken photos of other children or sent sexual messages, or at least taken photos of other children. They may be more likely to have taken photos of themselves or sent sexual messages. And because of sort of the legalities of that, we want to be just checking in on the use of electronics. There are a lot of challenges that may come up. Oh, sorry, I'm jumping ahead. I can see one slide ahead of me. So actually, once we've gone through all of the details about the sexual behaviors that the child exhibited, we also want to do a quick assessment of sexual abuse. Again, we know not all children who have PSB have a sexual abuse history, but there is some link for some children. So we want to do an assessment. And typically what we do is we just ask, has anyone broken these rules with you? If they say no, we move on. We're not going, we know that we're not trying to dig for more information. If they say yes, we want to praise them for their bravery, and then be mindful of the fact that this isn't a forensic interview and we're just trying to collect the minimum information necessary to make a report. We also may ask them about other concerns and symptoms or behaviors. So what kinds of things they get in trouble for, what happens at home or at school when they get in trouble, etc. We like to assess with the children what their thoughts are about participating in treatment and what their goals might be. Some children are really good at identifying goals, some may struggle, but we want to check in with them. And then once we are finished with that interview with the child, we do a follow-up with the caregiver where we talk with them about what the child shared. So did they share about the behaviors, or what behaviors did they share, or sexual behavior rules did they share about breaking? And then we want to provide, praising of what we can for this child to this caregiver. So they did share and they were remorseful, or they seemed to regret their behavior, or they were able to identify really positive goals for services. For children and their families, when there's been problematic sexual behavior, the parent-child relationship can be cracked or fractured. It may not be as positive as it once was. And so we want to provide those positive messages, because that can go a long way for caregivers who are struggling. Like I was about to say a minute ago, there can be a lot of challenges that arise during an interview with a child. They may deny or provide sort of an incomplete admission, so they give you some details, but you know that there is more to it. I want to talk about this first point in particular. So it is not uncommon for youth to be reluctant to talk about the times that they broke a sexual behavior rule. They may not trust you yet. They may have really strong anxiety or other negative emotions. They may just be defiant and they don't want to talk about it. We would prefer that they could talk about it and, give information about what sexual behavior rules they broke. Denying it or refusing to talk about it in our clinic is not a symptom of pathology, and it's not them being unemotional or callous. Children vary in their moral development, and depending on kind of where this particular child falls at, they may not be at a point where they quite understand the impact of their behavior on others. They may be driven more by this desire to avoid punishment, and so they don't want to talk about it, even if you've told them there will be, no punishment for what they talk about. Again, they may just not yet trust you, may not have developed that relationship yet. So we are not, we don't see this denial or refusal to talk as as something that doesn't allow them to participate in treatment. And what we often find almost all the time is that children who don't share in the initial intake through the course of treatment are able to talk about what occurred and provide more details. It just takes them a little bit longer. Being mindful of time, I kind of want to move through this next section pretty quickly, but in addition to the interviews, we also do some structured assessment measures. Currently, the only structured assessment measure of sexual behaviors in children is the Child Sexual Behavior Inventory, the CSPI, which was developed by William Friedrich. It's for children 2 to 12 years old. It's a 38-item measure that looks at the frequency of sexual behavior. Caregivers report, and scores give you kind of a total score that you can use to compare to children of the same gender and age. So sort of looking at a normative sample of sexual behaviors. It does have a cost associated with it, and it is managed by PAR. So you can see at the bottom of the page, I do have a link to where you could purchase that measure if you were interested. In addition to the original 38 items, several years later, in some of his subsequent publications, Dr. Friedrich added several items that addressed sexually aggressive behaviors, which had not been included on the CSPI. These items aren't ones that go to the total score or used kind of in that normative comparison, but are still useful to collect. So for instance, the 4 items that we actually add to our intake packet touches other children's private parts after being told not to, plans how to sexually touch other children, forces other children to do sexual acts, and puts finger or object in other child's vagina or rectum. So more significant or aggressive behaviors we want to assess for. In addition to the sexual behavior measure, we like to collect a broadband measure of internalizing and externalizing concerns. There are several of them available. These are just 2 that I have used and I know that are good examples: the Behavior Assessment System for Children, the BASC, or the Child Behavior Checklist. They both have a youth report version, a parent report version, a teacher report, and both have their own individual strengths. But it's just useful, again, to have that general internalizing, externalizing concern information. Also, for children with suspected or known trauma histories, we like to obtain a measure of their trauma symptoms. So trauma symptom checklist for children, or the trauma symptom checklist for young children, or the UCLA for the DSM-5. Those measures all have a cost associated with them, but can allow you to do a normative comparison. What we actually use is the Child and Adolescent Trauma Screen, which is a free measure, the CATS. It's a screener, so it's very short. It goes through all of the PTSD criteria. But again, we just want some sort of measure of trauma symptoms that then we can track over the course of treatment. Last few points. So completing the assessment, like I talked about, we follow up with the caregiver about what the child shared. We review next steps in terms of the timeline for recommendations. We like to give handouts to our families with the sexual behavior rules and some recommendations for safety and monitoring, as well as handouts or information about the National Center on the Sexual Behavior of Youth website, our NCTSN fact sheets. And if indicated, based on the behaviors and the concern, we start safety planning in that moment. So we talk through more high-risk situations and how the caregiver is going to have eyes-on supervision. We want to make sure that we're assessing or addressing home and school, potentially other situations where the child might be around other children, and make sure that there's a good safety plan in place for all of those settings. We want to really praise those positive steps. Want to make sure that we're considering if a report needs to be made and who that is. So you need to be aware of your own statutes in your own states. And then after the assessment, we may want to contact collateral sources like schools or Child Protective Services, etc., to get additional information if for whatever reason we didn't get it in the intake from the caregiver. And we want to be thoughtful about how much information we need to share if we're getting information from those collateral sources. So we may not need to give the school a ton of detail in order to get information about their academic and behavioral functioning at school. So really quickly, I'm running a little bit long, but just some conclusions. The goal of all of this and all this information that you're collecting is to really inform your clinical decision making, help you decide what treatment options are best. We also want to think through or remember that this assessment is your first in-person contact with this family, and they've often been through a lot before they made it to you. And so we want to provide them with hope for the future, education to address their misconceptions and what myths they may have, providing education about what treatment will look like and how it can be helpful for them. And we want to make sure that we're supplementing our clinical interview information with those structured assessments to really help round out our clinical decision making. If you're interested in clinical decision making, as I said earlier, my colleagues Shel Millington and Amanda Mitten, who are both licensed professional counselors, will be leading webinars next month on this particular topic. And last but not least, our NCSPY and all of our work is supported by grants from the Office of Juvenile Justice and Delinquency Prevention, and I do not speak for them, so I have to say that as well. Thank you.
Thank you so much, Erin. That was wonderful. It did run a little bit long, so we don't have as long as we usually do for questions, but I wanted to give you the full time possible just because it was just so chock full of incredible information. So thank you. Very concrete and thoughtful. So I'm going to start with a couple of the quicker questions. When you were putting up the images that you use with children to define body parts and so forth, we got two questions about that. One from Jessica. She asked, can you recommend a place to get these type of images?
Mm-hmm. That is a great question, and we had gotten permission from the author of these to utilize them and to share them in presentations, but we, I think, had just gone to sort of a medical, what's the word I'm looking for, medical assessment is where we found them. I could follow up with more information for that particular person, or later. I would need to check with the team about if we can share these items or these images. I think we're also on the hunt to look for more updated ones. So I don't have a great answer for that. I apologize.
Okay. And another related question, are these pictures also used for youth between the ages of 13 and 18? That was asked by Vanessa.
So for, this is particular for an assessment, and thank you for asking that. I didn't clarify in the beginning. For children who are 12, 13 and under, for older children, you may want, you may use something different. You may not ask quite the same way. So the assessment may look a little bit different than you would for younger children. So you potentially could use them. I don't believe that we do with our older youth, but this would be specific for the 12 and under.
Okay. So moving on to into a different direction. I'm sorry if I'm mispronouncing this person's name. Janane, maybe? How do you address shame, guilt during or after the interview process regarding the broken rules?
That's a great question. And so what we do through the course of the intake, if we notice a child is, really having a strong emotional response, we will, again, stop and do those relaxers and talk through how they're feeling. Typically, kind of in the assessment, we're not going to do as much in-depth around the emotions, but we will still talk about the fact that this is a clinic that we see a lot of children who have broken rules. If it really becomes something that we would need to talk more with them because they're really upset, we may talk about the idea of, what shame is versus guilt. But just, again, trying to remind them that this is a clinic for children who've made these kinds of mistakes before, made these bad decisions, but that we've been able to help children make good decisions in the future. And so I don't know that we get, much more in depth than that in the assessment. But we may have some of that conversation if we notice them having a really strong emotional response.
Wonderful. We have a question about the assessment piece. How do you see this type of assessment fitting into a high school setting versus clinical, especially with adolescents with intellectual disabilities?
That's a great question. So this would be more for a clinical setting. I think within a school, you have to kind of know within your own school and your own state kind of what is allowed for you to discuss. Part of what we have these conversations in our clinic is we get permission from the caregiver. The caregiver is aware of what we're going to be talking with the youth about. So if it were to be in a school setting, we want to make sure that the caregivers are aware of what you're discussing, and that it's in a private setting that they could discuss. For children who have more cognitive delays or intellectual disabilities, we see those children in our clinic as well, and really it's more forming the questions at a level that they can understand them and answer them, and thinking through how to sort of target the assessment questions at their level, and then also using that information to then guide treatment recommendations and what will be most helpful for that particular child. So I don't know that we have a specific outline for children who have more delays, but just, again, thinking about kind of the language that you use and what you ask them or how you word your questions. But we do have those children come through, and there are some resources on the NCSBY website. If you go to the resources tab, that looks at resources for sexual behaviors and sexual behavior problems in children with cognitive delays or developmental delays.
Thanks, Erin. Just to let you know, Jane Solovsky wrote in and she said that we can we meaning NCSBY, can send recommendations for books and resources for images that can be posted together with the PowerPoints. So we'll be able to put those up at nearypress.org
Thank you, Jane.
/webinars. Yes. One more question, and then we're going to have to wrap up. Ruth asks, what are common challenges that arise when interviewing caregivers about problematic sexual behavior?
That's a great question. There are potential for a lot of potential challenges. So sometimes what we run into is caregivers that simply don't know the information. Maybe the child was just placed with them, or they just never really knew what the information was. And so in that case, you want to think through, are there other other individuals that we could collect information from in order to get more information. We try to get whatever we can from those caregivers in that situation. Sometimes what we find is caregivers presenting with a really strong negative opinion about the youth. Maybe they're calling them really negative names, or having some really strong beliefs or concerns about what the behaviors mean for their child in the future, that they're going to be a sex offender or something like that. And so what we have found is aligning with the caregiver about their fears, kind of coming at them, not using their language, but understanding their concern and reflecting their emotions, and then again providing that education, and that those details about recidivism rates or what we know from research can help to kind of soften that view for them. And then I'm also thinking that there are caregivers sometimes that they don't really believe that their child engaged in the behaviors, and that can be a challenge as well, because we might have concerns about if they would potentially supervise as well. And so sometimes that's using the information from the child interview. If the child did share about behaviors that occurred. Sometimes it's just kind of checking in with the caregiver about why others might think that the child engaged in those behaviors and things like that. There are, of course, a number of caregiver concerns, but those are challenges that may come up.
Thank you so much, Erin. We unfortunately have to end the question and answer period. And there are additional questions that came in. And what I'd like to suggest to those of you who are still on the webinar that have questions is that you be in touch directly with NCSBY, and one of the incredible members of the faculty there will be able to help you, I'm quite sure. Erin, thank you so much. This has been wonderful. This, like we said before, is the second in our mini webinar series from NCSBY, so you have another chance to hear more next month. So we're going to move on just to the closing slides. We have a little bit more information for you that I think will be helpful. Our CE process recently changed. Paid CE credits will be available for psychologists and social workers for all of our webinars during this 2017-18 series. And for details about how to obtain the CE credits, you can visit nearypress.org/webinars and read through all of the answers about how you access CEs. We also, just so you know, we have a newsletter with NEARY. I'd like to let you know that we publish it monthly. It's a research to practice newsletter, and you're automatically signed up to receive it by being part of this webinar, and we hope you find it useful. Again, we'd like to encourage you to become a sponsor of this webinar series. We're thrilled to be presenting a brand new slate of webinars this year, and it is driven by the feedback that you, our audience, have provided about what topics are most useful to you. And when you sign up to be a sponsor, as thanks, you receive 2 of NEARY Press's popular titles, Current Applications and Current Perspectives, or 2 new books if you've already received these. And if you become a sponsor now, you're guaranteed seats to not only this season's remaining webinars in April, May, and June, but also to all of the webinars in next year's webinar season. You're guaranteed 15 seats if you're an organization, so that is a really great benefit to becoming a sponsor. Sponsorship is $98 for individuals and $250 for organizations. If you're interested, please be in touch at info@nearypress.org, or you can always give us a phone call. And the next slide will show you the wonderful sponsors that we have for this year's webinar series. Thank you to all of you so very much. If you like this webinar, you can see previous webinars on our website at nearypress.org and also on Neary Press's YouTube channel. It's possible to pay for CE credits for all past recorded webinars. And again, a huge thank you to Erin for such a great webinar, and to all of you at NCSPY for the amazing work that you do. And thank you to all of you for attending. I'd love to hear from you, to get your feedback, so please be sure to complete your evaluation form when you close out the webinar. Thank you very much for being here, everyone.